Hello everyone, this is Dr. Neha Jain. I'm a third year postgraduate student in Oral and Maxillofacial Surgery, and today I'm taking a session on suturing. Now, suturing is considered to be one of the most basic skills in surgery, but it is also one of the most important skill for a successful surgical outcome, not just for surgeons, but also for general practitioners. We will be using the surgical instruments, simulation instruments by Simutomy, and I will be taking you through the basics of suturing, the armamentarium required, the principles, as well as some most commonly used techniques of suturing. So what is a suture or what is suturing? It is nothing but the approximation of the edges of the wound or the edges of the incision to aid in healing. So we retain the sutures until healing takes place. For example, in the oral cavity, we retain sutures for 8 to 10 days, and for extra oral wounds like the skin, we retain them for 2 to 3 weeks. And we also use suturing for ligating of the blood vessels and to arrest hemorrhage, right? So, what are the goals of suturing? One of our most primary goal is to approximate the wound edges and give tension to the edges of the wound so that until the healing takes place, we hold the tissues together in apposition. Another important goal of suturing is to aid healing by primary intention, because we know that primary intention is quicker than secondary intention. It has low inflammation and low post-operative pain and also less scarring. So we whenever possible, we try to aid healing by primary intention. Another goal is to protect the wound from foreign bodies, from microbes, as well as from the clot getting dislodged. Like intraorally, after an extraction is performed, we don't want the clot to get dislodged. So most often, a figure of 8 suture is placed. What are the most ideal requisites of a suture material? So a suture material should have good tensile strength so that it does not break down before the tissue has healed. It should have, the knot should not slip. It should not untie on its own. It should have good biocompatibility. Some of the natural suture materials evoke a tissue response. So the trend is shifting towards more of synthetic materials because we can manufacture them based on the requirements. Another requirement of a suture material is that it should have good handling properties, it should be economical, and it should also be sterilizable. So back in the day, the suture materials were in these reels, and these threads would be wound in a curved needle, the eyed needle, but they have to be sterilized separately. So now we have suture materials that come pre-packaged in this way. The thread and the needle are already wound, and they're sterile as well. So coming to the suture materials, they can be classified into natural as well as synthetic. They can be classified also based on absorbability, that is absorbable materials and non-absorbable. When we talk about absorbable suture materials, the mechanism of absorption is either by enzymatic action or by hydrolytic action. And they can also be classified based on the coating. Some of the materials are coated, like chromic catgut. Chromic salts are added for better tensile strength, or Vicryl Plus is coated with triclosan for antimicrobial property. And they can also be classified into monofilament or multifilament. We see that a lot of suture materials are braided, so that is a multifilament suture material. So that was about suture materials, not going deeper into each material. The next armamentarium that is most important is our needle holder. So needle holder also come in various sizes depending on the area of suturing. They do come in longer and shorter sizes based on the accessibility also. For intraoral suturing, especially in the third molar areas, we need a slightly longer needle holder. So needle holder is a ratchet type of instrument. I'll show you the grip when I'm giving you the demo. The next important armamentarium would be the scissors. So scissors are either straight or curved, again based on accessibility. Some areas you need to use a curved scissors to reach the hard to reach places. And the next important armamentarium would be the tissue holding forceps. They can be toothed or non-toothed. The tissue forceps obviously helps in grasping the tissues with more ease. Then coming to needles, we use curved needles. They're again classified based on their sizes, based on their curvatures, lengths. So we most commonly use 3/8 size of needles. So they can be 1/2 of a circle, or 3/8 of a circle, or 1/2 of a circle. And they can be eyed or swaged. When I say eyed, that means there is a tiny eye over here, like a normal sewing needle where a thread is wound or tied. But these are not used now because eye needles are actually called traumatic needles because they are thicker at the portion of the eye, and they cause more trauma to the tissue when they're passed through the tissue. So now we use swage needles which do not have an eye. Swage needles are also called atraumatic needles. So these swage needles, they have the thread already inserted inside. So in these packaged needles, they're always swage needles. Then based on the cross section of the needle also, the needles are classified. They can be round body, they can be cutting or reverse cutting. So based on the tissues that we're suturing, for example, keratinized tissue, they're a little firmer or harder. So we use a reverse cutting needle, but in fragile tissues, we use a round body needle. So this was about the armamentarium used. And of course, the star of the session is the suturing pad. So suturing pads are available in layered or unlayered ones. So for a beginner, the unlayered ones are a better option. But for advanced learning, these layered suture pads are a better option because they are divided into layers such as skin, subcutaneous tissue, the muscle, and the fascia. So that would help in a better understanding. And this is the dental suture pad. So this is the extraction socket. So after extraction, if you want to suture the socket, this will help in learning that. So let's dig into the demo. So let's get into the demo of the suturing techniques. This is the needle holder that we'll be using. So there are two grips. One is the scissor grip, which is in this way. Your index finger will be placed here and it will help you to maneuver the needle inside the tissues. The other grip is the palm grip, which is in this way. Some surgeons also prefer to use this grip. This is a needle. This is an eyed needle which has a tiny eye here where the thread is wound, but these are not commonly used in surgical practice. We use these pre-packaged suture materials. So you see here, open here, so you just tear it open from here and take out the needle with your needle holder, and the thread is already wound inside. So some of the basic things you need to look out for when you're looking at your suture material is the size, which is 30. Now coming to the sizes range from 5 to 12. So 1 to 5, the sizes increase in thickness or increase in diameter from 1 to 5. But coming from 10 to 12, the sizes will decrease. What I mean to say is 30 will be thicker in diameter than a 60. So this is 30 and this is most commonly used in oral cavity. And this is senti silk, braided coated silk, and it is non-absorbable surgical suture. So as I already mentioned, sutures can be classified as absorbable or non-absorbable, and every suture material has a different half-life or absorption time as well as a dissolution time. What I mean by absorption time is the amount of time it takes for the suture to lose 50% of its tensile strength. And what I mean by dissolution time is the amount of time it takes for a suture material to be completely degraded into the tissues. So this is a senti silk. So I'm going to open it here and show you how to grasp the needle with a needle holder. So this is how you So I'll also be telling you some of the principles of suturing while showing it to you. So you always hold the needle 1/3 of the distance from the eye or the swaged end, or 2/3 the distance from the tip of the needle or the pointed end. Do not hold the needle, do not grasp the needle at the tip, as the tip might become dull, and you do not want a dull needle because dull needles will cause more trauma to the tissues. And do not hold the needle over here at the eye or the swaged end, because that will cause that could cause the bending of the needle, or it could separate the thread from the needle. That was the first principle. The second principle is always enter perpendicularly to the tissue surface. What I mean perpendicular is when you enter the tissue surface, the needle has to be perpendicular to the tissue surface in this way. So this has to be perpendicular, and always follow the curvature of the needle when you're passing it through the tissue. Follow the curvature of the needle when you're passing it through the tissue. Do not try to remove it in another direction, as that can cause the tearing of the tissues. Then the next principle is the tissue should be, the tissue that is grasped should be equidistant on both the edges of the incision line. For example, if it is 2 to 3 mm on this side, it should be the same on this side as well. So it is equidistant. Try to follow the rule of 3, where there is 3 mm from the incision edge to the where you have inserted the needle, and there is also 3 mm between adjacent sutures. So always equidistant. Another principle is the needle should pass from the movable to the fixed tissue. So if you're suturing a flap, always first insert the needle on the movable end of the flap and then to the fixed tissue. That will bring about a better control over your movable tissue, and we're also trying to suture the movable part of the tissue to the fixed tissue. So from movable to fixed, from thinner to thicker, and from deeper to superficial tissues. Also remember, the tissue should not be closed under tension, as this will strangulate the blood vessels and it could cause necrosis. So when you're tying the knot, use firm pressure but not too much tension, as that could cause necrosis. Another rule that you can follow in the oral cavity is that always try to place the knot on the buccal side, so that the tongue will not interfere with the knot on the lingual side, and because that could cause opening up of or untying of the knot. And it also helps because when you're doing the suture removal, if the knot is on the buccal side, it is easier to remove the suture. So the first suture technique that I'll be demonstrating is the simple interrupted technique, which is sometimes also known as solitary sutures. They're independent of each other, and the advantage is that even if one breaks, the integrity of the closure of the wound will still be maintained. They're easy to learn, but they do require skill and time. And this is how you place the suture. Hold the flap with the needle, with the tissue forceps, and enter it at 90 degrees, equidistant on both the flaps, trying to follow the curvature of the needle and getting it out of the other side. You can try to get it out of each flap single time, but if you're experienced, you can try to get it both at once. And then we're going to place a surgeon's knot. Try to put all the knots on one side of the flap, not in the center of the incision. So those were two throws in the clockwise direction, and this is a single throw in anti-clockwise direction. So this is a surgeon's knot, and then we're going to secure it with one more knot, which is known as a square knot. Then we're going to hold both the ends together, and we're going to cut the edges. So these sutures are independent of each other. So even if one breaks, the wound closure will still be maintained. So I'm going to demonstrate one more, holding the tissues with the tissue forceps and taking a bite on one side of the flap, getting it out of the other flap, trying to maintain equidistance. And getting the entire thread out. You have to be careful to leave enough over here, the shorter arm, so that it is there for tying. Then two throws. So I'm doing two, these are called throws, and I'm doing them in the clockwise direction. So we give two throws in the clockwise direction and we grab the edge of the shorter arm and we place the knot on one side of the flap, not on the incision line. And then we give one clockwise, anti-clockwise throw, one anti-clockwise throw, and this makes the surgeon's knot. Then to secure it, I also like to place a square knot. So this gives adequate and this is how we'll cut it. So if you can see, both the knots are on the same side, and can you see how the tissues have approximated? The tissues have already approximated. So this was a simple interrupted technique. So the next technique that I'll be demonstrating is the simple continuous. It is this, it will start off in the same way like simple interrupted. Take bites of both the sides. So this is a faster technique because we're not giving placing a knot every single time, placing a knot in the beginning and the end. So place the knot. Securing the knot in this technique is very important because one of the major drawbacks of this technique is that if once the suture gets cut, the entire wound opens up. So this is how we'll knot it. And the difference is that we'll only cut the shorter arm, we'll not cut the longer arm of the thread. And then we'll continue in the same fashion as simple interrupted, taking bites of both the tissues. So this will form a series of diagonals. In this way, you will be able to appreciate it when I place a few more sutures, grasping the flaps on both sides. So this gives equal tension to the entire wound because it is continuous. When you're starting off, you can try to enter one flap at a time. I'll just show you how. So you can first try to come out of one flap in this way. And then come out of the other side in this way. But if you're feeling confident, you can try to take bites together, bites of both sides of the flap together in this way. So as you can see, we have formed diagonals. We have formed continuous diagonals, and to knot it in the end, we will just in the same way take the bite. We will grasp this loop here and we will take the throw and we will knot it here. And take the ends together, just cut. So the next technique is continuous locking. It is similar to the simple continuous, but we will lock each suture. Start off with a simple interrupted. Place the surgeon's knot. But only cut with the shorter arm as in the continuous. Take the bite. And when you're taking the bite, when you're taking the needle out, pass it through this loop. So you will be forming a kind of a L here. This suture technique is a little tricky to master, and you might also need your assistant to hold this part taut. So again, showing it again. Pass it normally how you would in a continuous, and then pass the needle through this loop. So if you can see, this locking, this kind of locking is being formed on each side. So this is how it will look. We'll place a few more. Pass it through the loop. And I'll just show you how to knot this kind of suture. Just pass it in the same way, but instead of passing it through the loop, just tie it how you would tie a simple continuous. This is how it looks. Make sure they're all in the same line. So the next technique that I'm demonstrating is vertical mattress. This is majorly used for deeper wounds. What you can remember for this technique is that far, near. One suture is, one bite is taken for the deeper tissues for support and adduction, and the superficial bite is taken to approximate the edges and to avert them. So I'll just show you how it is placed. So take it further from where you would take the normal suture. So can you see if this is further from where we would have taken the simple interrupted? Get it out of the flap. Then go a little further again. Then on the same side, you will take another bite a little closer. So this is, those two are the far, and this is the near. So these will be a bit more superficial than the previous one. The far bites are deeper, and the near bites are superficial. Can you see how they're getting approximated? So these are also called vertical mattress because they are vertical or perpendicular to the incision line. So this is how a vertical mattress looks. I'll show you one more time. Far and deep. This is the other far. and the other one, the second bite, is near and superficial. Near, near. Try to grasp it very gently from the tip. Don't notch the tip. And then this is a little longer. So this is how the vertical mattress looks. So this everts the tissues very well. This is used for deeper wounds, and it is at two levels, the deeper level as well as the superficial level. So the next technique is the horizontal mattress. I'm placing it right next to the vertical mattress so we can differentiate between the two mattresses. We'll start off by giving a simple interrupted bite. And then we will go from this side to the opposite side. If you can see, a line is forming in this way. In vertical mattress, it was perpendicular to the incision line, but in horizontal mattress, the suture is horizontal or parallel to the incision line. Then we will give a knot. So this is how a horizontal mattress looks, where all the sutures will be parallel to the incision line. In vertical mattress, they will all be perpendicular to the incision line. So the next technique is the figure of 8. This is a dental simulation pad, and this is an extraction socket. So we'll start by taking a bite on the buccal side. And in the simple interrupted, we usually would take a bite on the opposite side, but in this we will take a bite diagonally. So this will form a kind of one arm of the X or the figure of 8. And then adjacent to the previous one, we will take one more bite and go diagonally again back to the buccal side. So if you can see, a cross is already forming here. A figure of 8 is already forming here. And then we will suture it. Then we will knot the suture in this way. So this gives very good protection for the clot that is inside the extraction socket, and it does give approximation of the flaps as well. So this is how we will knot it, and then we will cut the knot. This is a very simple suture to place in an extraction socket. So I've already shown you how to place a suture. I'll just show you how to remove a suture. So hold the suture by the knot. Place the scissors underneath it and just cut it. Hold the suture by the knot, tug at it a little bit, and then pass underneath and cut it with the scissors. So this is how a suture removal is done. Thank you.